Fuck.
एहन मुठ रहते न भाभी कोई न ओकरा देखते बुझलिए जते जते लोग ई त अहाँ के
Hey everyone, we'll be starting in a bit. We're just waiting for everybody to join. Please mute yourselves.
बिल्कुल
चालू हो रहा
एक नंबर की चालू है
So guys, I'm assuming most people have joined this. So let's begin the session. Welcome everyone to today's workshop. This is Essential Sutures. We're really excited to have you all here. I'll introduce myself. I'm Tanya. I am the Junior Executive Officer of the Professional Development Wing here at Clinicase. And the workshop you'll be attending today is Essential Sutures. So this is a prerequisite workshop to a more hands-on workshop that will be launched later. And here you will be learning the basic surgical skills for the sutures. So the things that you'll be learning here today, initially the posture and the handling of instruments, the 5 basic sutures in surgery, the 2 basic knots in surgery. So here we have with us Shivani Gholab, the founder and director of CCE, Clinicase Essence. So welcome Shivani. And we have, of course, Dr.Krunal Soni, who will be conducting this session. So Dr. Krunal is an orthopedic surgeon at B.J. Medical College and Civil Hospital, Ahmedabad. He's extremely passionate about teaching, and we're honored to have him here with us today. So without further ado, let's start this session. Welcome, sir. Over to you.
Hello. Am I audible?
So you're audible. There's a bit of disturbance. Yeah.
Hello?
Yes, good now. Yes, sir, you're audible.
Am I loud and clear?
Yes, sir. Ready.
Okay, so we'll just start. Okay, friends, good evening. I am Dr. Krunal Soni. I am an orthopedic surgeon, and currently I'm working as an assistant professor in Department of Orthopedics at B.J. Medical College and Civil Hospital, Ahmedabad. I welcome you all for this evening, and this will be the first of the 3 sessions which we have planned. We'll take you from basics to advanced. We'll gradually build it up. And at the end of the 3 webinars, we do plan to have a practical hands-on workshop so that you can actually practice what you have learned in these webinars. And we plan to do it in the forthcoming couple of months if time permits and if COVID permits us. We would do it maybe state-wise or region-wise. Let's see how that goes. So this session today would focus on very basic things. We would talk about how to maintain a proper posture during surgery and while taking the sutures, how to handle instruments, especially the needle holder and the needle, which are the most important parts which you're supposed to handle them. Then we'll talk about 2 very basic types of knots used in surgery. One would be the reef knot, and other will be the granny's knot. And last, we'll learn about 4 or maybe 5 common types of skin sutures which you're supposed to take. And you might be taking it right now during your internship, or you would take in future, maybe at the PHC level or UHC level or while doing an internship. So we'll start with posture during surgery. All of you might have noticed my screen. My screen is there, right, Tanya?
Yes, sir.
Okay. Just bear with me. I guess I'm not able to do next. Okay. Yeah. So we all have seen that the kitchen countertops are at a particular height. And while ironing on the iron board, we have seen that the iron boards are of particular height. So have you ever noticed or have you ever questioned that what dictates the height of the kitchen counter tables or the ironing board, or for that matter, the height of the OT table? What really governs that? So what governs is you are supposed to stand at the height and work at a height by which your upper limb function is maximally utilized and it is maximally optimized. Now, what do you mean by function of upper limb as in maximally utilized and maximally optimized? It is said that upper limb functions are maximally optimized when both the shoulders are not abducted and they are at the sides. The elbows are at also the sides. The forearms are a bit extended and the hands are palmar flexed. So in this position, as it is shown in the picture, the upper limb function is maximally optimized and it is ergonomic and it is not tiring and it is not in fatigue. And you can work for an extended duration of time while maintaining this posture. Now, say suppose what happens if the table height is way above. As you can see in this picture, if the table height is way up according to your height, your arms would leave from the sides, your shoulders would be abducted, and this will cause a fixation of the shoulder girdle. It will cause decreased efficiency of your movement of pronation and supination, which is required while you perform surgeries. And needless to say that it causes stress and strain in your back muscles. Now let's see a situation where it is reverse. What happens if the table height is too low? So as you can see, if the table height is too low, this causes you to stoop over and bend over. And of course, it is not a very nice position to work for an extended duration of time. So again, I'll stress upon my point that the optimal table height is such that you don't have to bend over or stoop over. Your shoulders are absolutely at the sides, not abducted. Your elbows are just besides your body. Your arms are in a bit of extended position and your hands are palmar flexed. In this way, you can work for an extended period of time without fatiguing yourself, and you can actually increase your efficiency and efficacy both. A similar situation of us, I can relate it to everyone would have seen how golfers play golf and during the tournaments. And once they go on that field, you might have noticed that they take a lot of time adjusting their posture. You'll see that they adjust their ankles, they adjust their knees, they adjust their hips, and they adjust their spine to perfectly align themselves, and then only they'll take that swing. We should definitely learn from that, because before starting for the surgery, you should properly align yourself, make yourself comfortable, and then you should go for that first bite or the first stitch or perform surgeries as well. So I cannot highlight more importance of posture during surgery, because that is the first step which you are going to do before starting the surgery or before taking sutures. Posture is of utmost importance to increase your efficacy and efficiency while you are performing surgeries or taking sutures as well. So we have finished with the posture part. Now I will just take a few moments to adjust my camera so that you're able to see what I'm doing, because now on there won't be any presentation. I'll just share with you what I do, and we'll take it from here. Tanya, I need 2 minutes to set my camera so that people can see what I'm doing, right?
Yes, sir, sure.
Okay.
I think so. Even others can get ready with their pillow covers and needles and thread and sutures if they have any, because now everyone, you guys have to start participating. As Dr. Krunal Soni, sir, he'll be teaching us how to go about the workshop. So this is an interactive workshop. So even all of y'all can just set up your table. And we had circulated a message that what all will be required for the workshop. So please be ready. So please unmute yourself.
I can't hear you. So my table is visible, right?
Yes.
Okay, we'll start. So next part which I wanted to discuss is how do you handle instruments. the most important instrument for a surgeon would be a needle holder and of course a scalpel, but we are not discussing scalpel today. We are discussing more of how to take sutures. So I'll keep my attention and focus towards a needle holder. So this is a needle holder. Basic part says these are the two rings. This is a ratchet or the locking mechanism. This is the shaft, and these are the serrated ends. Now, most of you would be surprised and amazed or even shocked to understand and to know that the way we hold a needle holder today is actually not the way it was supposed to be meant when it was invented or discovered back in 1800s. So the way they introduced the needle holder was you're supposed to do something where it is a palming of the instrument.
Hello.
So what is palming of instrument? Place the needle holder in the axis of your palm. So the axis starts from the index and between the index and the middle finger. And your little and ring finger will hold one of the edges, one of the rings. You can see, everyone can see, right? And your thenar eminence.
Hello. Hello.
Yes, please.
Sir, I'm not able to see the instruments.
You're not able to see. Okay, I'll just.
I think so. You need to stop sharing your screen.
Sorry, come again.
You need to stop presenting and sharing your screen because the attendees can see your presentation.
Okay, I'll do that. Fine.
So also, even on the video, I'm not able to see the instruments as such.
Could you move your hand a little ahead? Or push the camera a little forward?
Yeah, just one sec.
Yeah.
So, any better?
It's a little bit more into the field.
Into the field, okay.
Yeah.
Now?
Yeah, now it's
better?
Yeah.
Okay. So I'll start again. For the ones who could not see it, so there's something called as a palming of instrument. You're supposed to keep your needle holder in your palm between the axis. The axis of the palm starts between the index and the middle finger. So you place your needle holder in between that axis. Your ring.
I can't see the instrument.
I'm just explaining only one instrument. Are you able to see?
No, sir. It is visible.
Yes, sir. It's visible.
I think
Why is
so.
there
You guys can pin the video where the instruments can be seen. You can pin it in on your laptop or screen on your.
Okay. Yeah. Cool.
So if yes.
Fine by everyone?
Yeah. Yes, sir.
Everyone
Yes,
is
sir.
okay?
Yes, sir.
Yeah, good.
Good. Okay, I'll start again. No problems. So palming of instrument, you keep your needle holder between your index and your middle finger. That is the axis of the palm. Your little finger and your ring finger, that will hold one of the rings of the instrument, and your thenar eminence would hold the other. And this is the way it was actually when it was discovered. It was supposed to be held this way, and your index finger will support the shaft. And this way you are supposed to hold a needle holder. This is a bit difficult way. It takes time for you to lock and unlock. And now for locking and unlocking, as you can see, my thumb will press one of the rings volarly, and my ring and index finger will press dorsally. And this way you lock and unlock, lock and unlock, lock and unlock. This is a bit of technically difficult way to do it, but if you are able to do it, this is the perfect way, a textbook way to do it. Now, I'll just share a small story with you how I learned to do it. When I was posted in my surgical program in my final year. So our HOD took our first class, and he made sure that we all have one needle holder with us to show us how to hold it. Because of course we were taught wrongly by everyone the way they used to do it. And he taught us this way of doing it, and he made sure that we always carry a needle holder in our pockets till we are able to make this sound. He used to call this click, click, click sound. If you can appreciate this. I don't know if everyone can hear this, but he used to tell us that till you can make this sound very comfortably, keep the needle holder in your pockets. So this takes time. It will take practice, but if you're able to do it this ways, this will have a perfect control over the instrument, because your thumbs, your two fingers and your index finger, every finger of yours is somewhere in contact with the instrument and you can perfectly pronate it, supinate it, and be in control of it. The more recent way, or the way in which we all hold our instrument these days is we put our thumb in one of the rings and we use the ring finger in another ring, and we use the index finger to support the shaft, and we do pronation and supination. This is a much easier way, a more recent way, and also a correct way to do it. So choice is yours. If whatever ways you are comfortable using this instrument, you can use it. Both are correct ways. Now it depends on your comfort. Now, many of you would have one question, that why do we put the ring finger and not the other fingers? Quite of course. So the
Excuse me,
reason
sir.
is yes.
Sir, could you please close your face camera, because the YouTubers cannot see the instruments because it's not getting pinned over there.
Come again, I didn't get you.
Can you close the camera on your phone, the one with your face camera?
Tanya, I've done the settings. It's now the instrument screen is in the
All right,
spotlight
perfect.
for everyone. So on the YouTube as well, they can see.
All right, perfect. Thank you.
Perfect, done. Okay.
Yes, sir, you can
So
continue.
now, why don't we use other fingers rather than the ring finger? The main movement which is required when you are using this needle holder is pronation and supination of your wrist. This is the main movement which is required. Now, if you try to use your thumb and index finger, just do it right now with me. You will see that the movement of pronation and supination is very cumbersome. It is not efficacious and it is tiring. Do it with me. You will find that you will have fatigue in your arms while doing this movement. Try with the same middle finger. Again, it is not very ergonomic to do it. Now, if you use your ring finger, you'll come to know that it becomes a bit easy. Life becomes a bit easy holding the instrument and pronating and supinating your wrist again and again, which would be required when you are suturing it up. One tip I want to give to you while handling the needle is now. I won't be taking everything, how to handle forceps and how to handle scissors, because we don't have time for that. And I guess I'll just highlight the important points. I want to talk 2 points about the way we hold a needle. Now, I guess everyone is able to see my needle holder and needle, right? One thing is always make it a point from now onwards that whenever you insert a needle anywhere in the body, let it be deeper tissues, let it be superficial tissues, let it be skin, your needle should have an entry which is perpendicular to the skin or the deeper tissue. Your entry should always be perpendicular. And that means your needle should go in bang on 90 degrees. That is one thing which you take it for life, that whenever you put your needle, it has to be a 90-degree entry. Now, why am I stressing so much for a 90-degree entry? The reason is whenever we insert our needles in the skin, specifically in the skin, when we insert our needles, the needle makes a circular hole through which then the thread passes and we tie the suture. Now, what will happen if the needle passes a bit obliquely? So what I'm talking now is microscopic, of course, it is not visible to naked eye. But if you have an oblique entry, you don't have a perpendicular one, you suppose have an oblique entry. So this oblique entry creates an oblique hole in the skin from which the suture will pass, and again you'll tie it down. But that oblique hole now makes the hole more prone to microabscess formation and leading to infection. This is proved. There are papers which say that. Anyone who has interest in this, I'll forward you the papers and you can go through it. But for now, take it to point that whenever you insert your needle, it should be bang on perpendicular and not at an angle. Second thing which I wanted to share about handling a needle is, so as you can see, I'm holding the needle perpendicular to my needle holder, right? So this is my needle holder, okay? And this is my needle. You can see this is perpendicular. And when you are doing this, when you are holding the needle perpendicular to the needle holder and you try to take the bite, as I explained, perpendicular, you'll see that it is a bit difficult to take that bite 90 degrees. But life becomes a bit easy if you hold the needle at an angle. I guess everyone will be appreciate, okay, what do I mean by an angle, right? So I was previously holding the needle at perpendiculars. This is perpendicular. Now, if you try to hold the needle at an angle to your needle holder, and then if you try to take a bite, you'll see that it is very comfortable for you to enter perpendicular and take your sutures. Anyone has any doubts in this? I'll repeat it.
Excuse me, sir.
Yes.
Sir, is this procedure, the entire procedure, similar for left-handers as well? Because
Yeah,
I am a
it is.
left-hander.
Yes, absolutely. It is similar. Absolutely. No difference in dexterity. No difference.
Thank you so much, sir.
Yes. Anyone has any doubts in these 2 points which I explained about needle? I will repeat it again. I have no issues. Okay, I guess everyone is good to go, right? So now we'll start with 2 types of knots which are used in surgery, and we'll learn 4 different sutures. Okay. So firstly, I have done a makeshift arrangement in my home. I had a cloth. I would just show what I have done, and you can just mimic the same. This is a pillow cover which I had at my home. So what I have done is I have doubly fold this pillow cover, 1 fold, 2 fold on one side, then similarly 1 fold and 2 fold on the other side. This looks like a wound. So everyone can do the same with me. I'll give it like a couple of seconds for you guys to adjust. Just 2 folds. Make sure that you have something in between so that it looks like a wound. It mimics like a wound for that matter. Okay, so I guess everyone would be sorted and ready with their instruments. So in surgery, there are 2 main knots right now at this basic level which you are supposed to remember. One is called as the squared reef knot, and other is called as a granny's knot. Now, what is the difference? These are the 2 most basic knots which you can do with a needle holder. So a squared reef knot and a granny's knot. We'll first go from the granny's knot, and then I'll show you what is a squared reef knot. And while doing so, we'll know what is the difference and why both are used, for both are used. So again, as we have demonstrated, I guess it is visible, right, Tanya? Be with me.
Yes, sir.
Okay, so I have held my needle at an angle to the needle holder as we discussed. I'll be entering perpendicular to the skin as we discussed. Never try to take both the bites at the same time. Always take 1 bite at one time. Okay, pull out your needle from one end. Hold your needle with the help of forceps. Try not to place your hands over the needle holder and injure yourself, because that will happen at one point and another in time, and you don't want yourself to go through all those post-exposure prophylaxis. So try not to touch the needle with your bare hands. Always use a forceps. Always use a forceps. Okay, so again, we'll go for second bite now on the second side. If you want a good suture and if you want your skin margin to be good, you make sure that you are equidistant at both the ends. So from where you took this bite to the skin margin, you are equidistant at the opposite end. So if you do this, you will have a good looking suture. So what I always do is, as soon as I'm done with biting both the ends, I keep my needle aside on a sterile area away from me so that I don't injure myself. Now, firstly, we'll be doing something called as a granny's knot. What is a granny's knot? Now, this is a short end. This is a long end. Okay. Now you imagine a circle between the short and the long end. Just imagine a circle, and you're supposed to do a circular movement. So this is called as a hitch or a half hitch. So I will rotate my long end on my needle holder, catch hold my shorter end, and just always pull the short end away from you. I'll do it again. So this is my long end. This is my short end. I imagine a circle between these 2 ends. Now what I'm going to do is do 1 loop of long end on my needle holder and catch hold my short end and bring the short end towards the opposite direction. Okay. In granny's knot, now second step. Always in surgery, you go for 3 hitches or 3 loops. So we did our first loop. Okay, this is my first loop. In granny's knot, in second loop, you go in the same direction. Again, we imagine a circle. My needle goes on the loop. and I catch hold the short end and it goes in the opposite direction. Okay. Again, one more. Same loop, catch hold the short end and bring it at the opposite side. So if you're doing it in a circular way, all on the same side, this is called as a granny's knot. Okay. Now we'll do what is called as a secure knot or a squared reef knot. So once again, needle is at an angle, perpendicular entry to the skin. We presume this is skin. Bring it out. Again, the same thing. Let your needle go away on a sterile area, away from you, so that you don't injure yourself. So this is my long end. This is my short end. My first loop will be the same. I'll hold the short end, bring it to the opposite direction. Now, the difference in granny's knot and squared reef knot is, in squared reef knot, we go in the reverse direction. Catch hold the short end, bring it to the opposite direction. And the third would be the same. So why squared reef knot and why a granny's knot? It is said that the squared reef knot is much more secure knot. It is much more stable knot, and this knot won't slip. While the granny's knot, it has a tendency to slip it away. So always in surgery, wherever you use a squared reef knot and you don't use a granny's knot. There are situations where you're supposed to use this granny's knot, but where in those situations where suppose there is gaping of wound. For example, this is a wound, it has a gaping. So what you do is with granny's knot, you close that gaping, but you do a squared reef knot on the top of it. I'll show it to you. So you never leave a wound with granny's knot, you always secure it with a squared reef knot. That's the point which I'm trying to make. So suppose this wound has gaping, we'll hold the needle at an angle, we'll go in 90 degrees, come out through the first wound, take a bite on second, sorry, my bad. So first loop, hold the short end, bring it on the opposite side. Again, and suppose there was gaping in this. So what we are trying to do is, we are trying to oppose these margins. Again, we are going for granny's knot. So it will be the same direction. Again, one more in the opposite direction. But now the last one will secure it with the square reef knot as we'll go reverse. And we'll secure this. Always a squared reef knot will secure your wound. It will prevent the knot from slipping. A granny's knot is one which will help you slide the skin, but it won't let you secure the wound. So if you want to do a granny's knot, you do a granny's knot, but always secure it with a squared reef knot. Is everyone clear with these two basic types of knots? I don't mind doing it again. Guys, I need answer. You can unmute and say yes, that's okay.
Yes, sir, we are clear.
Excuse me,
Come
sir,
on,
could
be
you-
a bit louder. I
Sir,
guess
can it-
I can presume all of you guys would be surgeons, and surgeons have a voice.
Can it be shown again?
Yeah. What both the parts are the one?
Sir, can you please focus on that reverse part, that reverse knot in the reef knot part?
Reef knot. So I'll go again for the reef knot. Okay, we'll start it again. So we are doing a squared reef knot. So I'm holding my needle at an angle. We take the entry perpendicular from one end. Go in again. Okay, so we are doing a squared knot, which is recommended in surgery everywhere. Wherever you do a knot, it has to be a squared knot at the end. So the first loop, imagine a circle between the two ends. This is my short end. This is my longer end. Imagine a circle. First loop is clockwise. If you want to say that, bring your short end towards the opposite direction always. In squared reef knot, the second loop is always in the reverse direction. And pull the short end away. The third would be over and above. Got it? I can repeat as many times as you want till you learn the difference between granny's knot and a square knot. Because trust me, I should not say it, but even surgical residents don't know what is the difference between a granny's knot and a square reef knot. I want you guys to know it for now and for life. So any doubts?
Yes, sir. It's clear to us as of now. Sir, I have one doubt which is slightly unrelated to this topic. May I ask it?
Please go ahead.
Sir, in our medical school, we have been advised to use a suture pad, that is a silicone pad.
Correct.
Sir,
Correct.
should we buy it, sir? Is it really good?
So, Udit, right?
Yes, sir.
Yeah, Udit, I'll answer all these questions at the end. But right now, if you have any question related to how you take a square knot or what is a granny's knot, I'd like to answer that first.
No, sir. Thank you so much.
Sir.
I'll take your question at the end. I'll answer you.
Thank you, sir.
Excuse me, sir.
Anyone else have a confusion about what is a squared reef knot and what is a granny's knot? You can just say it. I'll do it again.
Excuse me, sir.
Yes.
Sir, can you repeat granny's knot once more?
Granny's knot. Okay, I'll do it again. So, in granny's knot, needle at an angle, perpendicular entry to the skin. Take it out from one end. Again. Okay, so we are doing a granny's knot. We know that it is not a secure knot, but still we would like to do it because it is helpful sometimes for closing of gaping wounds. Okay, so in granny's knot, this is my longer end, this is my shorter end. First loop, is it visible? Okay, fine. First loop is same. This is my circle, an imaginary circle between the two ends. First loop is same, clockwise. I'll pull the short end towards opposite direction. In granny's knot, even the second loop is in the same direction as the first. You don't have to do it reverse. The third loop is also in the same direction. Is it clear?
Yes, sir. Understood, sir. Thank you so much.
Understood. Okay, fine. Anyone else has any doubts?
Sir,
Don't mind it doing it again. Yes, please.
Sir, the third loop in reef knot is clockwise or anti-clockwise?
So in reef knot, see, first step is same. First loop is same clockwise. In reef knot, since we want that knot to be secure, the second loop which you do is an anti-clockwise. And that anti-clockwise locks in your suture. It secures your knot. And it does not let your knot slide away. While in granny's knot, since we are doing both the loops in the same direction, it causes sliding. Got it?
Yes, sir. Thank you, sir.
Okay. Anyone else? Everyone is okay with granny's knot and a square reef knot.
So can you please show the square reef knot again?
Okay, no problems. So at an angle, 90 degrees to the skin, first bite, it's visible, right? Yeah. Again. So in squared reef knot, the first loop is the same. Okay. There's a circle. I'll go clockwise. First loop, hold the short end and bring it towards the opposite side. This is first loop. In the second loop, I'll go counterclockwise. Okay. So firstly, we went clockwise. Now I'm trying to go counterclockwise. I'll show it again since it is gone. So first loop, clockwise, grab the short end, bring it to the opposite side. Next loop is counterclockwise, grab the short end, bring to the opposite side. And this locks your suture. As you can see, it locks your suture perfectly that it won't slide now. It just won't slide. Any confusion?
No, sir. Thank you.
Okay. Anyone else didn't get it?
Excuse me, sir.
Yes, please.
So since square reef, you said
Two of you are speaking at the same time. Just go one by one.
Hello, sir.
Yes.
Yeah, in the second square, the square reef knot, so you said the second knot will lock it.
Yeah.
So why is there a need for the third knot
Yeah,
as
so
well?
in surgery, you want your knots to be absolutely secure. So it is a rule of 3 that you always put in 3 knots. You never leave it at 2. You always put in at 3, especially when you are closing some small vessels and some gut and things like that. So you don't want your knot to slip it away. So for being extra cautious, you always put in 3 knots. Always.
Okay, sir, thank you. Okay, sir, thank you.
Okay. Any more questions about this? Happy to answer now.
Yeah, sir. Why is always the first bite taken away from the surgeon and not on the side of the surgeon?
Okay, so you want to ask that why am I pulling the short end away from me?
No. The bite. I mean the bite. The first bite is taken away from the surgeon. That is on the other side of the wound and not, on the side of the surgeon.
So that is comfortable. See, I got your question. Try doing it with me. Let's see, even I'll try to do it. So we hold our needle and needle holder like this. And if you try to take it from the side of me, it becomes a very ergonomically difficult to take the suture. You see, it's not very handy. You try doing it yourself. So it is more of ergonomic and no as such reason. It is a bit comfortable for you to take the bite on the opposite side. Because the rule is you never cross your hands. If you can see, while suturing or while doing anything in surgery, you never cross your hands. So if you're trying to take a first bite towards you, you'll eventually cross your hand, which is not very comfortable and it is not recommended as well. So the easier way to do is you want your life to be easy while you're operating. So the easier way is you take a bite on the opposite side.
Got it, sir. Thank you.
Okay. Anyone else? Any questions? So I presume and assume that all of you now have understood the difference between a square reef knot and a granny's knot, right?
Yes, sir.
Come on, guys. Some answers are welcome.
Yes, sir.
Yes, sir.
Clear.
Yes. I know that it's a Sunday night. It is already 8 p.m. or 9 p.m. I guess. But come on, some answers are welcome. Okay, so now we are coming at the last part. I'll just show it to you. Yes, who is this?
Kindly mute yourself, attendees.
If you don't have a question, please, I would request that you mute your mobiles. Okay, so now coming at the last end of this is different types of sutures. Now you'll have to give me a minute because I'm running out of sutures here. I'll have to grab one. So give me a minute. Shivani, till that time, or Tanya, you can take some questions if they have.
Guys, if you have any questions, please drop it in the chat box. All the questions that you were given during registration, we'll be addressing all of those towards the end of the session. But if you do have any extra doubts, put it in the chat box or keep them ready.
I hope everyone's liking this workshop. Even feedbacks are welcome. You can put in your feedbacks in the chat box, and there will be a feedback form later on. You can give in your feedbacks in the form as well.
Thank you, Abhilash.
Yes. Any questions? Yes, or we should go ahead.
We're good to go, sir.
Good to go? Okay.
Yeah.
So now I'll be showing and demonstrating few types of sutures. For example, we'll go through simple interrupted sutures. We'll go through horizontal mattress sutures. We'll go through vertical mattress sutures, and we'll try to finish it with 2 types of continuous sutures. I'll explain you as we go through, right? So first is simple interrupted sutures. It is very simple as the name suggests, and we have done it. So in simple interrupted sutures, again, my needle is at an angle to my needle holder. I'll be inserting it perpendicular. Take it out. Keep your needle away. So we'll always use a squared reef knot whenever we are doing any type of closure of wounds. So from henceforth, whatever knots we are doing, will be using a squared knot. First loop, clockwise, hold the short end, bring it towards you. Second would be an anti-clockwise, since it's a secure knot or a reef knot, and lock it. Always take a third one. Is everyone okay?
Yes, sir.
Is everyone okay with this? This is a simple interrupted suture. Most
Yes, sir.
commonly, yes, most commonly used for all the lacerated wounds, which are neat and clean wounds, like a knife wound or like a fall wound anywhere on the forearms or on the head or on the tibia, anywhere, abdomen. Simple interrupted suture closed with a secure square reef knot. Everyone is okay with this, right?
Yes, sir.
Yes, sir.
Clean wound, sharp wound, a knife wound with minimal or no gaping, you can use simple interrupted sutures and just sew it down, right? Now, next would be next is a box suture or a horizontal mattress suture. Suppose if you have wound which is a bit of gaping, and suppose the skin around it and the tissue around it is a bit swollen, so that your edges are not exactly approximated, but there is slight amount of gaping in that. For example, as I've shown here, that there is a small amount of gaping between the two margins. So whenever you have a wound which has slight amount of gaping, or the wound on the skull, or the wound on the proximal tibia, where the tissue is tense due to swelling, you use something known as a horizontal mattress suture. Now, how we do that? I'll just take you there. So initial steps are the same. Hold your needle at an angle, insert it perpendicular, bring it out. Never try to take both the bite at the same time. Never try to do that, please. One bite at a time. Okay. Bring it out from the opposite. Now, if you want your wounds to be nice, as I have told you before, the distance between your entry and margin on both the sides, make it sure that it is same. It will come by practice, but if you know that you have to do it, so you'll do it right all the times you try. So I have entered my skin at a distance of say 0.5 centimeter from in the upper margin. Make sure that you have an equidistance of 0.5 centimeter on the opposite end as well, for you to have your skin edges nice and inverted. Okay. So first step remains the same. In horizontal mattress suture or box suture, the next step is different. How different it is, we'll see. So we assume that there is a bit of gaping here, and we want that gaping to close with a suture. So what we do is, we have entered here, and then we re-enter from the skin margin near me to the skin margin away from me. Move your needle away from your area in the sterile area, and then same principle. First loop, bring it to the opposite side, reverse, lock it, secure it. Always in surgery, a third knot. So this is your horizontal mattress suture, also called as a box suture. Anyone didn't get it? I can do it again.
So could you please repeat it once?
Yeah, sure. So the first step is the same. We assume that there is a minimal gaping or slight amount of gaping. So first step, same. Bring it out. So then you'll re-enter just where you left. We have entered here. We've got it out from this side. This is my longer end. This is my shorter end. Now where my longer end is there, I'll again go in. Because there is slight amount of gaping, we want to close that gap. We want to close that dead space. So I'll go in again, just from the sides. Try to be equidistant at all the times. Move it away and get it out. You see, as I pull my long end, you'll see that the skin will oppose each other, right? Whatever gaping is there, that gaping will be minimized. And then same first loop, bring it to the opposite side. Next loop, lock it in the reverse way. Always a third loop. Everyone okay with this? Yes.
Yes, sir.
Answers?
Yes, sir.
Yes,
Yes, sir, we are
is good. Everyone is okay with it. I don't mind repeating for any one of you.
Sir, while
Yes.
re-entering, you don't take one bite at a time. You just go it through the wound and back again.
Sorry, I am not able to get you. Please speak louder.
Sir, while re-entering the wound,
okay,
you didn't take like one bite at a time. You just went through the wound.
Actually, this is a cloth. So it is very difficult for me to demonstrate it to you because it's a cloth. So, it's not as smooth as a skin. But yes, you are right. I didn't go one at a time, which I should go. But for practical purposes, it's a bit difficult.
Okay, sir. Thank you.
Okay. Yeah. Anyone else? Any questions? Any confusion? How to take a horizontal mattress suture or also called as a box suture?
So when we re-enter on the same side that we took for the second bite, do we go at the same distance as we came out?
Yes. So equidistant. One entry, skin equidistant. You make sure that you are equidistant from the sides also. So actually, being equidistant does not change your surgical results. It changes your cosmetic results. Your scar would be a bit thinner and it will be easier for the scar to heal. So equidistance is for cosmetic reasons. It's not for surgical reasons.
Thank you, sir.
Okay. Anyone else? Any questions? Yes, please shoot.
Sir, could you please show it again?
Yeah, sure. So same principles, basic principles remain the same. At an oblique, I'm holding the needle at an oblique angle. Entry should be perpendicular. Bring it out. Try to remain equidistant. And now, what equidistance I was telling is, these two should be equidistant from the point we are entering again. So if you keep this in mind, you will slowly bring that in practice. You make sure that you enter here and you come out from the skin is same as you come out from skin and enter again here. This is equidistance to again where we are going back. So go it in, get it out. Again, go it in. And try to come out at the same level where your first bite was. So this will give you a neat, clean scar and it will be good in cosmetic also. So pull it. As you can see, when you're pulling it itself, the dead space will be closed. So first throw, short end grasp, bring it to the opposite side. Again, secure it. And the third one. Okay, clear?
Yes, sir.
Okay, any confusion? Anyone wants it to repeat? Don't mind it. So I would just assume by the silence that everyone has got it. The next would be a vertical mattress suture. Now in wounds where there is significant amount of gaping, and especially when you're taking sutures of the skull, you're taking sutures of proximal tibia, you're taking sutures of distal tibia, of limbs, where there is less of soft tissue and where the significant swelling causes gaping of wounds. So in that gaping, we use something called as a vertical mattress sutures, also called as deep superficial sutures. Why? We'll just see. Suppose this is my wound. It has significant amount of gaping. and you want this gap to be closed by suturing. So basic principles remain the same, but here, whenever you try to take the first bite in vertical mattress suture, you take a deep bite. What do you mean by deep bite? So you try to go through skin and take significant amount of subcutaneous tissue as well. That is called as a deep bite. So this would be my deep bite. First deep bite, bring your... Hello?
Excuse me, sir, you are not visible.
Yeah, I guess just bear with me 1 sec. Tanya, give me a moment.
Yes, sir, no problem.
Yes. Okay. Tanya, can you please mute me? One of my... Okay. Visible?
Yes, sir, it's visible.
Visible, right?
Yeah.
Okay. So I will go again.
There's a lot of echo. So can you mute yourself from your phone?
Yes, I've done that.
Okay, perfect. I think so we
Better?
can. Yes.
Okay. So we'll go again.
Okay, so the echo is still there. I think so you need to lower down your volume of the phone.
Any better? I've done that.
Okay, perfect. Yes.
Perfect?
Yes.
Perfect for everyone?
Excuse me, sir, it's still echoing.
Still echoing? Okay. Any better?
Sir, please come again.
So
Sorry?
which one would you like to mute? Krunal Soni. I'll mute that one.
Is it fine?
Sir, it's not muted yet.
So it's fine now. It's fine now.
Fine now. It's
right?
fine now. Yes, yes, sir. It's fine. You can
Okay.
continue.
Yes, sir. It's better now.
Okay, we'll start. It's fine and it is visible, right? Right. So we'll start again with the deep superficial superficial, or also called as a vertical mattress suture. Suppose this is a wound which is on the scalp or it is on the distal part of tibia where there is significant amount of gaping. If we have small amount of gaping, we can get away with a horizontal mattress suture as we have done before. But if there is significant gaping, there is a lot of tissue swelling. So we want something which can minimize the dead space. So basic principles remain the same. Oblique, and hold the needle at an oblique angle to the holder, perpendicular entry through the skin. Make sure that this is a deep bite. Deep bite means you will take a good amount of skin as well as good amount of subcutaneous tissue as well. That is called as a deep bite. So pull out your needle. Again, try to hold the needle as much as possible with the forceps. You'll take a deep bite here as well. So deep bite means again, good amount of subcutaneous tissue and good amount of skin. You pull it back and now you'll go reverse exactly parallel to what you have taken here. So you'll see and you'll understand what is parallel means. And this time you'll go superficial, as in you'll just take bites of the skin only. So this is a vertical mattress suture. As you can see, this will help in closure of good amount of gaping and if there is a significant amount of edema and dead space. So first loop clockwise, grab the short end, pull it, pull it, pull it, pull it, counterclockwise, pull the short end away from the wound. And third, always secure with the third knot. Okay with everyone? Anyone wants me to repeat it?
Please repeat this one. Can you
Yes,
please
come
repeat
again.
this one?
Louder.
Can you please repeat?
Okay,
Am I
I'll
audible?
go again. No problems. So this is called as a vertical mattress suture, also called as a deep superficial suture. We use this commonly for wounds which have significant amount of gaping. There is significant tension and there is a lot of edema and there is gaping. Okay, so you go first bite, you take as deep as possible of the skin and subcutaneous tissue. My bad, sorry. Pull it, pull it. You go opposite and take a deep bite as well. You want good amount of tissue here because you want to oppose everything. So for opposing, you want good subcutaneous tissue with the skin. Okay. Now you've taken deep. The second part of this is superficial. So this time you just want only skin coming and not the subcutaneous tissue. So be a bit superficial here, just the skin part. Just the skin and equidistance. As much as possible, be equidistant from both the ends. Okay, let your needle go away. First loop clockwise, short end, pull it close, counterclockwise for a squared knot. Lock it nicely and tight, and third. Any confusion?
No, sir.
Everyone is happy and okay with this?
Yes, sir.
Simple,
Yes, sir.
interrupted sutures, horizontal sutures, and vertical mattress sutures. Every one of you, all 62 are okay with this.
Yes, sir. Yes, sir.
Okay, so
Yes,
we'll
sir.
just wrap it up by last, which is a continuous type of suture. Continuous type of suture is not very commonly used, but at least you should know how to take them, because at times when you have elderly females presenting to you or elderly male who have a very friable skin, and or you have some trauma cases or fracture cases where you'll expect the swelling to go more after the surgery. In generally trauma cases or fracture cases, once you operate, the swelling is more after a couple of days and then it goes down. So in these situations, you want continuous sutures on your skin so that they hold the sutures well, right? One disadvantage of continuous type of sutures is if there is small amount of a discharge or if there is some infection, you have to take down the entire stitch line. You cannot remove just one suture like these interrupted sutures. See, for example, this is a stitch line and there is some collection which I noticed here. So what I can do initially is I can just take this one suture, let whatever hematoma or collection is there to drain out. But when we are doing a continuous suture, we do not have the liberty of just taking down one suture. As I'll just show it to you, the entire suture will go away. So that is one disadvantage of continuous suture, but nevertheless, you should know how to take them if required. So we'll start with continuous. There are two types of continuous sutures. Over and over type is one and blanket type is the other one. I'll just demonstrate both to you. We'll start with the continuous over and over type. So the first step remains same. I guess everyone can see me, right? First step same. Needle at an angle, 90-degree entry. Bring it out. Same process on the other side. Bring it out. And now you lock it. First throw clockwise, hold the short end, bring it to the opposite side. Second throw counterclockwise, hold the shorter end, bring it to the opposite side, and always a third knot. Okay. Now in simple interrupted sutures, we always cut our sutures at the same, but in continuous suture, as the name suggests, we do not cut anything. So we'll continue our sutures here as well. So now you again take this, repeat the same procedure and try to remember that you should be equidistant from all the knots which are coming further. So suppose I have left 0.5 centimeters from here. So again, same process. First, sorry. Again, same. You don't cut your needle. Oh, sorry, the suture. You just keep on taking it continuously. And you try not to go through the loop. Try to be equidistant for cosmetic reasons, and your edges would be everted if you are equidistant. I guess we have done a loop here. I'm sorry, my bad. We'll do it again, guys. Just give me 1 sec. We'll start here. So this is over and over type suture. I guess it's visible, yeah. First throw, clockwise, lock it. Second, counterclockwise, take it in the opposite direction. Third, always to secure it. Do not cut your suture at this end. since it is continuous. First, I guess the needle holder is really bad. Second, third. So you see, you take these continuously, don't loop it. You keep on taking this continuously. I'll just cut this one of it and continue suturing so that you can appreciate what is a continuous suture. So now, yeah. Okay, so this is continuous. This is not a bit of equidistance, but yes, you try to be equidistance. With skin, it is a bit easy. With cloth, it is a bit difficult technically for obvious reasons. So yeah, anyone, any doubts with over and over type of continuous sutures?
No, sir, I guess we can go ahead.
Hello, yes.
Sir, how to close this?
Cannot hear. Anyone, any doubts? I'll take it again.
So how?
Yes, please.
So how to close the suture?
I'm not able to hear. Be a bit louder.
So how do we close this suture?
So yeah, okay, fine. I was waiting for someone to point that. So when you want to close it, you loop it, you catch hold of one end, you tighten it. And then what you do is there is a loop here. So you tighten both the ends of it. One end and the second one. Neat. Then throw it well. Again, the same thing. Both the loops you are supposed to tighten it. You are supposed to tighten both and the third loop. Both the loops. Okay. Yes. Anyone? Any more questions? So as you can see, if this is my wound and suppose there is some collection in between. Now this continuous suture does not give me liberty to just take out one suture because it is continuous. So if there is any hematoma or any collection or any small infection, I'll have to take out the entire suture. So this is one disadvantage of continuous over and over type of sutures. Anyone else? Any questions?
No, sir.
Everyone is comfortable with this? Yes, 63 participants. Anyone? Any doubts? So we'll just do the last continuous blanket type and we'll finish this. Answers, guys.
Yes, sir, we can go ahead.
Sorry, come again?
We can go ahead.
Go ahead. Okay, just 1 second. So this is the last. I'm falling short of sutures today. Thank God I have many. So this is last continuous type of blanket sutures. This is specifically done in orthopedic injuries where you want watertight closure, where you don't want any dead space. That is the time when you use this blanket type of, or it is also called as a locking type of continuous sutures. Okay, so we'll start. First step remains same, oblique holding of the needle with the needle holder, perpendicular entry. go through first. Lock it and park your knot on one side. First throw, second reverse throw. So since this is Vicryl, this won't slide. With Ethylon, it usually slides. Okay. So you cut the small end, and now we are doing something known as continuous. Everyone is visible, right? You can see. Yeah. So again, do not cut the long end. Take a continuous suture. But here, what is the difference between overend type and avoids? Here we loop it. So you can see that I'm not directly taking out my needle. I'm bringing the loop of my long end and I'm bringing my needle from that loop. And you can see this is getting locked. Again, so I'll take multiple, you will appreciate what is, again, the same step. I'm getting this loop on my needle. This is my long end. Okay. I'm getting this loop on my end and I'm pulling my needle through that loop so that it becomes locked. Appreciate. This was not locked. Now this is locked. And when you pull, you can see that this is locked. I'll take a couple of more so that you understand. Same steps. Take out your needle and you bring your longer end, loop it over your needle and get your needle over above that loop. Couple of more. Anyone wants to ask anything, just shoot in right away. Same, get the loop on the needle and pull your needle on that loop. So this is called as continuous blanket type. The one we did before this was continuous over and over type. This is a continuous blanket type. Take the loop on your needle and pull your needle through that loop. I guess the last one, and then we'll just lock it. In the last step, even you're supposed to take the loop, okay, for knotting it, but this time you're not going to pull it through. So you'll keep this loop on your needle holder. Keep it, and then first pull it, pull both the threads, 1, 2, lock it with a square, again, pull both the loops, 1, 2, and last for done. Okay, guys, anyone? So this is your continuous blanket type. That was your continuous over and over type. Any questions?
So where are these blanket type of sutures used, sir?
Speak a bit louder.
So where are the second type of continuous sutures used?
So most commonly this type of locking sutures, locking continuous sutures we use in something called as, if you know TFL, you know there's a tensor fascia lata over a lateral side of the thigh. And whenever you want to suture it watertight or airtight, you have to use this continuous type of sutures so that it gets locked and there is no any dead space, no any collection.
Yes, sir.
Okay.
Okay.
Anyone else?
Sir, could you just show zoom in a little and show the entry bites? Or I'm just getting a little confused.
Come again. Speak a bit louder.
Sir, could you just zoom in a little and yeah, zoom in a little and just show show the entry bite? Like I'm just getting confused.
So you want to just see the suture, or you want me to take it again?
No, sir. I just want to know the entry bite.
Entry bite.
Yeah.
So this is my entry.
Like, could you just show it with the suture?
You want me to do it again?
Yes, sir. Like just the entry bite. I just want to know
I'll do it
which
for you. Yeah, fine. So we are taking continuous suture, okay, where we do not want to cut. This is a very small one. I guess I need one more. I'll try to take this. Okay. So first is first loop. Lock it. Second, short end, pull it. And third, always for securing. And you should park your knot on one side of the skin. So this is called as a parking of wound, where you catch hold the short end and then you just park your knee. And then you start taking continuous, whether it is over and over type or whether it is blanket type.
Yes, sir. Thank you.
Okay. Anyone else? Any questions?
So how do we know how tight a suture is, if it's too tight or if it's too loose?
Speak a bit louder, please.
So how do we assess the tightness of a suture, if it's too tight or if it's too
So
loose?
your skin margins, suppose these are my skin margins, if you can see. Your skin margin should always be neutral or it should be everted. It should never be inverted. Studies have shown that parallel skin lines and everted skin lines, they heal well. When the skin lines are inverted, that means that they won't heal well or they'll take a long time to heal well. So whenever you're suturing, make sure that you have end-to-end skin margins or your skin margins are slightly everted. Everted is good, but never inverted skin margins.
Thank you, sir.
Yes. Anyone else?
So, sir, in a gaping wound, why do we take the granny's knot first? And
Sorry, come
can't we
again?
do a why do we take a granny's knot in a gaping
So
wound
yeah,
first?
so granny's knot is also called as a sliding knot. So what happens is, suppose, for example, we want to close one of the gaping wounds. So for closing one of the gaping wounds, you want your knot to slide so that the dead space is decreased. In that case, initially we use a granny's knot so that your knot slides and your dead space closes. As soon as your dead space closes, then you want your knot to be secured. So over and above grannies, you do a reef knot.
All right. Okay.
Okay. Yeah. Anyone else?
So, Snesh, I had a question. In a wound of a specific length, if you decide to take any kind of non-continuous suture, how do you decide how many sutures you want?
I didn't get the question. Can you repeat it again for me?
Yeah. In a wound of a specific length, if you
Okay.
decide to take any kind of non-continuous suture, how do you decide how many sutures you want to take?
Okay. So your the doubt is how to space your interrupted sutures.
Yeah. And decide how
So
many.
generally, the rule is your two interrupted sutures, the distance should not be more than 1 centimeter for your wound to heal well. If it is more than 1, it won't heal well. So 1 centimeter is optimum distance, lesser is acceptable, more is not acceptable. So your suture should be 0.5 to 1 centimeter placed from each other.
Okay.
Especially, for example, when you are taking sutures of skin of face, where the scar is very, very important. In that case, you're supposed to use finer needles, finer suture materials, and you're supposed to place your sutures as close as possible so that you will get a good scar. But that is a topic of discussion for some other time. What sutures to use, where to use them is entirely different. Today, we are just taking two basic things, that how to take sutures, and then we'll build it up from there.
Okay.
Any more questions? If you have no other questions, then I guess some of you have sent me questions yesterday or day before yesterday, and I'd like to answer them. If there are no any questions here.
So I have a doubt.
Yes, please go ahead.
So in continuous type of sutures, we always have we tie the knot in the beginning and then we take the continuous type of sutures. So is there any other continuous sutures where we don't take the initial knot?
See, you will have to, Tanya, just focus on my other things. If you're taking a continuous suture, you will have to take a knot here. Otherwise, there is no way that your suture will hold it. And you'll have to tie a knot at the end. In continuous sutures, there won't be any knot between these two. But there will be a knot at the first start and there will be a knot at the end. There won't be any knot in between.
Okay, sir. Thank you.
Any more questions?
If you don't have any specific questions on sutures, can we move on to some questions that were put up during
Okay,
registration?
so I guess we take the questions which I was sent yesterday. I'll pick it one by one. Okay.
Yeah. So one was, is the silicon suture board that you get really good to practice knotting and suturing on?
Come again, please speak a bit louder. I'm not able to hear you.
Yeah. Is the silicon suture board really good to practice knotting on?
Yes, I'll come to those questions which you guys have sent me. And one of the questions in that was the same. I'll just get back to you. Let me take the list of questions, please.
I guess Tanya is reading the same questions that the document that was sent.
Can you share that document here, Tanya?
1 second.
I guess I got it.
Sir, I could read out the
Yeah.
same questions for you. Okay.
So I'll just answer. The few questions were really not pertinent to the topic of discussion today. So I won't be taking that questions now, but rest assured I'll answer them. So one of the questions is, how can we develop our surgical skills as an undergraduate student, especially in times of pandemic, where we are not getting any practical clinical exposure? Is it dexterity and ability to be precise with fine handling a necessity to pursue surgical field, or is it okay if fine skill motor skills aren't that good? So I do understand that seeing this current COVID situation, your patient contact and your clinical contact will be minimal. But that being said, you can practice it with whatever materials are available to you at home. Even a cloth is fine. A suture pad is all the more better. And you can practice right from now, because surgery is all about how many times you're going to repeat the same thing. The many times you do it more, it is going to get better at the end. So repetition makes your surgical skills beautiful. And I would not say that it is okay for you to not have fine motor skills, because see, as a surgeon, you will develop over next 20 or 30 years, whatever practice you're going to do as a surgeon. The very first case which you do, and maybe the case after 20 years, you'll realize that you have grown as a surgeon. You yourself will realize it. So it's a long due process. It's not one destination. It's a journey. So you have to embrace it. There will be good and bad times. You will probably lose some few patients here and there, but it's a long journey and you'll have to embrace it how it comes. And you'll get better each day, I guess, as a surgeon. Because if I think that, the surgeries which I used to do in maybe 2015 and the same ones, if I compare myself with 2015, are way different. So I've evolved myself as a surgeon, and that is the journey of all the surgeons. You'll evolve. Eventually, you'll evolve and you'll be better than what you were. So the third question is, if we don't have the suture kit, what else can we use that will be helpful to understand the suturing process and the hand movements? So as explained, you can use a normal cloth, and you can use Vicryl or Ethylone. That is the commonly available sutures, and handling with cloth material is a bit easy with Ethylone and Vicryl. It is not with other materials. So I hope that answers your question. As pandemic is hindering our clinical exposure, do you think students who aim for better surgeon? I've explained this well. You keep on practicing with whatever available resources you have at hand and whatever time you have. I mean, there is no other option you have available, right? So why not make the best out of whatever you have? One of you have asked me what inspired him to take up surgery as a specialty. Now, this is not exactly the question of today's discussion, but I assume that there will be a lot of to be orthopedic surgeons in this discussion, and I would like to tell them what motivated me to took up orthopedics. So, I'll just share a small story of when I was working as an intern in 2008 or 9, I guess. And while I was posted in all the other departments, It was good. I was learning as medicine and as a surgical intern and as an ENT and all the postings. But when I was posted in orthopedic surgery, so what was overwhelming for me is on one day you see a patient who is in a lot of pain, in a lot of agony, and is immobile, and he can't use his limb, upper limb or lower limb, and he's practically bedridden for one day. And that orthopedic intervention changes his life completely the other day. You'll see that the same patient who was crying the other day is maybe smiling the next day because he's out of that pain, he's mobile, he's able to use his limbs, and that transition is so much evident that I was taken aback that, your one intervention can change the life of a human being so much, and you are fortunate enough to witness it like in a couple of days. That made me take up orthopedic surgery. I mean, it is so satisfying to see that you can bring about a significant amount of change in someone else's life and you can witness it. So this was the go-to factor for me that I want to be a part of this, and that was the reason and that was the inspiration for me to take up orthopedic surgery. So one question is it true that surgery is monotonous and it gets boring after some time? Oh no, not at all. I'll tell you, surgery is one field which is not boring. You won't ever get bored as a surgeon. I mean, so for my life for last 10 or 12 years as an orthopedic surgeon, if I say that 10 years back I operated a case and today I have operated the same case, that's not possible. Every case is different, every surgery is different, and it will surprise you. The simplest of surgeries would at times surprise you, and the complex one would just be very simple. So surgery is a roller coaster ride. You just have to sit and just let it go, flow with it. So surgery is not monotonous, absolutely not monotonous. Since medical students are missing out on clinical postings due to pandemic, how can we still further our clinical skills? I have explained that as well. It would be really helpful if he could discuss the theoretical aspects in brief as well as the practical things. I mentioned a bit about handling, a bit about posture, a bit theory here and there. I guess not more than this theory is required at this basic level. In advanced things, we'll touch a few more theory as it is required. Please do tell us in what specific surgeries, what kind of sutures are used and in what way. So as I said, sutures is a very big and a very important topic. Yeah, I guess if I remember, it even comes as a question for final year students, So I will take up that topic of sutures, where to use, what is absorbable, what is non-absorbable, everything, but it'll come at a later date. You just wait for it. Is the silicone suture board really good to practice knotting on? Should I buy it? If you ask me in one line, yes, it is worth investing your money in. It is very good. The feel is nice and it is almost lifelike. So I would recommend you get a suture pad for yourself, maybe a couple of them, because till the time you have hands-on experience, that is a good hands-on experience for you guys to practice on. So the couple of more is the different sutures used for different parts and when are the suture removed. Again, I'll take up in sutures, but just to answer this question, most of the non-absorbable sutures which we use for skin closures, they take out on 8th to 12th day, depending on which area you have taken. On areas like face, where you don't want your scar to be very much evident, you take it out on maybe 7th or 8th day. On areas of abdomen and on limb surgeries, you take it out a bit late because you don't want your wound dehiscence. So you take it maybe 12 or 13 days, depending. But we'll touch this topic in future. What sutures are avoided in what circumstances? Just hold me for this time being. I'll answer all these questions in the coming up seminars or webinars. Can you give advice for practicing it in home? And yes, I've explained this. Yes. So these are all the questions which were given to me. I am more than happy to answer any else questions which comes to your mind, or we can call it a day. Yes. Hello, is everyone awake?
So, sir, there is a doubt in the chat box.
Okay.
Am I audible?
Yes, you are.
Okay. How to close blanket type of suture?
I'm not able to hear. Can you be a bit louder?
how to close blanket type of sutures.
I'm not able to hear. Okay. Chat
How
box.
to
I'll just see the
close
chat box. So I have a how to close blanket type of sutures. The same way as we close the over and over type. I can show it to you again if you want. Just one sec. Let me grab one more suture for you. So we'll just take a couple of throws in the blanket one for the one who has a doubt, and yeah, I'll show it to you. It's visible, right?
Yes, sir.
I'm visible, right, Tanya?
Yes, sir. Yeah.
Okay. So basic principles remain the same. Oblique, take entry perpendicular, same side, and we are using continuous. So we just would tie the knot here and park it at one side, right? First throw, lock it counterclockwise, bring it to the opposite side, and third knot. So in continuous ones, we are not cutting the long end, we'll just cut the short end so it is visible for you guys. Okay. So we are doing continuous blanket type where we want to lock it. So this is also called as a locking type of continuous sutures. Okay. Insert it and get the loop over your needle. Take out your needle through the loop. So, and pull it. When you pull it, you can see that it will get locked. Okay. I'll take a couple of more and then I'll just knot it. Again, get the loop over your needle. Take your needle through the loop and pull. So you can see it's beautiful lace-like pattern which will develop at the end of your wound.
Yeah.
Again, one more. Get your loop on the needle and bring your needle through the loop and lock it. Okay, so now here we are locking this. We have already passed your needle through the loop and you put your needle holder on the loop here. You do not withdraw it yet. Okay, pull it, and then you want to tie this. So what you do is simple, principle remains the same. Circle first, grab your loop and just tighten it. And make sure that you tighten both the ends of the loop, one and second one. Okay, same reverse. Take the loop, tighten it, and now secure it, both loops. So this locks your third. Okay. Yes. Is it clear?
Yes, sir.
Okay.
Yes, sir.
Okay. Anyone else? Anything? Any other questions? I guess let's call it a day. Thank you so much. Tanya, can you switch my screen?
Yes.
Okay. Thank you guys so much for still bearing this. This went on over and above the time which I had thought that it would be, but it was nice. This is the first basic session. We'll come up with more advanced as we imbibe this basic thing. practice it as much as possible with whatever materials and resources is available to you, because only and only in practice you'll come to know how it goes. This is theory, you need to practice it at home as well. So good luck, take good care, take amazing care of your family, and just learn well. Happy suturing.
Thank you so much, Dr. Krunal Soni. You've covered everything, sir, and I am pretty sure we've got many people. We've got many people on YouTube as well who are watching this continuously, and even the live chat there was going on. So, and as sir said that we have a series of workshops coming up, more advanced workshops that is definitely there, and we also have a national workshop program that we'll be launching. So regarding the suture pads and the silicone pads, just have some patience. We have a surprise for everyone, and the professional development team is working on it. So just bear with us a little. We have many announcements to and many projects to launch. Thank you once again, Dr. Krunal Soni, and thank you everyone for joining us.
Thank you.
Tanya, over to you.
Yes, so thank you so much. I mean, you do not know he has a very heavy, hectic schedule, and he's taken time out of his one free day, probably not even a free day, to come and take this session for us. So thank you so much.
Most welcome.
And it was extremely enlightening. We had so much fun too. So thank you for that.
Most welcome.
And guys, thank you so much for attending and being so interactive. Loved the session. Also, one last thing before you go, make sure you fill out the feedback forms that I'll be putting on the group. Make sure to fill that so that, it's easy to get your certificates issued. Only if you fill that can we do that. So thank you so much once again.
Thank you guys. Good night. Take care. Yeah. Bye-bye.